this week's gecko, which is on endoscopy. And this week, it's my job to thank everyone. Obviously, this is part of Project ECHO and the Gastro Foundation's efforts at gecko in South Africa. Yeah. All those who haven't muted, if you could mute. My voice is quite soft, so otherwise you won't hear what's cooking. And obviously, New Mexico and India are our hosts in terms of the logistics and support for all the gecko meetings. We received about 74 registrations: Mozambique, Namibia, Nigeria, Kenya, Mauritius, and about 40% are from various venues in South Africa. And so welcome to all of you. It's good to hear you, and we hope that you will interact with us because we have an interesting lineup for you. Today we have, we're going to focus on colonoscopy and quality indicators or key performance indicators, which is definitely something that you should give thought to in your own environment. And Kay Karlsson is going to start with that. And she will then be followed by Daniel Surridge, who's going to talk to us about the practicalities of managing colonic polyps. And hopefully that will be the ABC, because at my age, I don't know the X, Y, Z. So Kay, if you could unmute and please give us your talk. As I say, all of you, please feel free to interject at the end, and to please post questions in the chat. I will be monitoring the chat and conducting things afterwards. Over to you, Kay.
Okay, so thanks, Sandy, and good afternoon to everybody. So I just want to try and get the full screen. Can you see the slides, Karen? Because they haven't come up. Hold on, let's just do it again, because they came up when we practiced.
I can see if you can go into presentation mode.
You have done exactly the same as before, but it just hasn't come up on my screen. So I'm just going to stop.
To exit.
So I'm just going to stop the share again. I don't know what it's done differently. So, okay, so can you see the slides now before I go to full screen option, Karen?
I can see them. You need to go into presentation mode.
You know, when I do that, it's not working this time. It just, my screen goes blank. It's exactly the same as I did before.
I think if you can put your cursor on the first slide and then go into presentation mode.
Yes, that. No, it's not working.
Can I share from my side?
Yeah, do you want to share from your side? I don't know why it's done this, because it worked perfectly when we ran through and I've done nothing different.
Okay.
But as we said, today things seem to have been a bit funny.
Can you see it now?
Yeah, I see it now.
Okay.
So I could see this, I just couldn't go to full screen. When I went to full screen, it went blank.
Okay.
Okay, will you be able to move the slides for me?
Yes,
will I be able? Okay.
I'll have to do it for you.
Okay, that's
just tell
fine.
me when to move to next slide.
No, that's fine. So thanks everybody. Sorry about that. We tested all this earlier and it was working fine, but these things do happen. So obviously when we're doing procedures in medicine or doing anything in medicine, one of the things that's very important is we want to actually know, are we doing things well and are we doing things properly? And often we think we are, but if we don't have data to prove that we are, then we actually can't say we are. So one of the things a few years ago that was quite topical within the gastro community was the quality of colonoscopies and the teaching of colonoscopies and whether we're actually providing a good service to our patients. So what we decided to do at Wits Donald Gordon was to actually audit our practice and have a look and see, were we actually doing as well as we thought we were? So next slide, please. So what I've got on the first slide is just to show you the number of procedures that we did. So you can actually see that over the 2-year period, we did almost just over 3,500 colonoscopies. There are 12 doctors who work in our endoscopy units, and we have included all the doctors in the total number, but during the presentation, you will see that I present data on certain doctors. And we're a little bit of an unusual hospital in that we have some doctors who work full-time, and we have some doctors who work in the state hospitals and do their private practice at Vitz Donald Gordon. So the ones we've included in the individual doctor data are those that have done more than 50 colonoscopies at Vitz Donald Gordon per annum. They clearly will do more colonoscopies in the year because they are also working in state, but for statistical reasons, we haven't included all the 12 when we look at the individual doctors. But the total figures do include all their procedures. So if you have a look, you can see we do a range of ages. We're only allowed to do adults in our endoscopy unit, so children won't be reflected on this. And the majority, as one would expect, are over the age of 50. But interestingly, we do about 30% of our patients in those between the age of 18 and 50. We have a slightly female predominance, which I think would be expected. Okay, next slide, please. So we also broke them down into racial groups because there's been a lot of discussion as to whether we see the same number of polyps in the different racial groups, and without identifying the race groups, we wouldn't have been able to look at that data. We are a private hospital, so we have a predominantly white population with about 15% of Indians and then just under 10% Black Africans. Because it is an endoscopy unit, you will see that most of the patients are outpatients, with only just about 10% being inpatients. Next slide, please. So the first thing we looked at was, why are we actually doing our procedures? And a significant proportion, around 40%, are for screening. And I don't think this is unexpected. We are very aware of screening. The population of patients in South Africa on medical aid are educated and aware of screening. And also we have an open access program, which until COVID hit, we had a number of GPs that could send their patients directly to us. We did suspend that during COVID because we felt that the risk-benefit ratio had to be discussed directly with the patients so that patients could decide if they wanted to continue with their care, particularly when we were initially confronted with COVID and we were under the hard lockdown. The next highest incidence of indication was for both cancer and polyp surveillance. We have quite a number of surgeons in our hospital who do cancer surgery, and therefore this is not an unusual number. And as you can see, about 8% of all our patients are scoped for inflammatory bowel disease, either for surveillance or for investigation of symptoms. Next slide, please. So what were the quality indicators that we looked at? So firstly, we look at cecal intubation rate. So that is the percentage of times that you reach the cecum when you start your procedure. And that's extremely important because when doing a colonoscopy, if you don't reach the cecum, then you're going to miss lesions. And we all know that right-sided lesions can be missed. We know that they can be more difficult, and they're extremely difficult to see if you haven't even got there. So reaching the cecum is extremely important, and there are international benchmarks with which we can compare ourselves. We also looked at the polyp detection rate. So when you look in the literature, you can see what is referred to as polyp detection rate and adenoma detection rate. The problem with adenoma detection rate is it's incredibly labor intensive because you need to upload all the histology, and we have managed to do that for one of the years, but not for both. And therefore the numbers that you need to reach are different, and I'll explain those as we go through the slides. Also, what's been shown is that withdrawal time is important. So if you get to cecum and then you just pull your scope out, clearly you're going to see less polyps than if you spend time looking. The withdrawal times that have been recommended is a minimum withdrawal time of 6 minutes. And in some studies, they've suggested that 8 minutes may be even better. With the timer that we have on our endoscopy stacks, it was a little bit challenging because the timer, when you press it the first time, it starts. When you press it the second time, it stops. And if you press it a third time, it resets. So we did struggle because your withdrawal time is not supposed to include polyp removal. But I'll explain as we go through the slides how we were able to correct for that. Obviously, bowel prep is also extremely important because if you get in there and just see poo, then you are not going to see polyps. So it's probably, in fact, the starting point of where you can concentrate on improving your quality. And then just for interest for myself is we actually calculated our terminal ileal intubation rate. So this isn't really in the literature, but what I wanted to know was in the scopes where we said we had to get in the terminal ileum, we really wanted to, what percentage of the time could we actually get in? Next slide, please. So firstly, to look at completion of examination. So we looked at cecal intubation rate for all the colonoscopies together. And the benchmark that you need to attain is more than 90% of your procedures. And in fact, you can see that in both years, we achieved well over that. And then screening colonoscopies only, you need to reach more than 95%. And the reason for the difference is that obviously when you're doing all your colonoscopies, you may be confronted with people who've got obstructing lesions or severe diverticuli, and that's why that benchmark is a little bit lower. But again, with the screening colonoscopies, we were above the benchmark, which was great. And then when we looked at the scopes where we wanted to get into terminal ileum, so that would be those patients who maybe have terminal ileal Crohn's disease, or you were investigating for anemia or for diarrhea, we were actually also getting in there over 90% of the time, but there is no benchmark for this. Next slide, please. Okay, so obviously at the outset of your colonoscopy, you need a good bowel prep. And we haven't done quite so well here. There is a bit of debate as to whether our nurses are just, they like a really clean bowel. So they kind of were quite rough on us if they weren't clean, but that's a good excuse. But we were using just a standard scale that we'd used ourselves because we had a number of different doctors and they all reported their bowel preps differently. The problem with that is that it wasn't an internationally benchmark reporting system, which we have now moved to. So if we look at all colonoscopies, we got about 76% where the bowel prep was said to be good or fair, and outpatients was better than inpatients. And this is a well-recognized phenomenon. Often your inpatients are sicker, they are less mobile, and they may not have adequate access to the fluid that is required to drink with these preps because they're dependent on other people to bring things to them. So outpatient preps are usually better, and that is exhibited here, but we did not reach our target benchmark of 85% of good preps. Next slide, please. Okay, so let's move on to the withdrawal time. So the median time was just over the 6-minute mark for all the scopes. If we look at those that were less than 6 minutes, so we're a little bit too quick, it's actually between 45 and 50%, depending on which year you look at. So what we actually did, because some of these will include polypectomies, is we looked at the median time for negative result screening colonoscopies. So those were screening colonoscopies where no polyps were found and our median withdrawal time was a little bit too quick. So, and in fact, it got quicker in 2019, but we had a surgeon who retired at the end of the 2018 period, who was a very fastidious and very careful doctor, and I think his removal made it appear quicker. I don't think we were all getting quicker. I think it was the removal of someone who was doing a good job from the statistics. Next slide, please. So if we look at our polyp detection rates, you can see that we did reach the benchmark or greater than the benchmark of 25% in both years, with quite an improvement from 2018 to 2019. What we actually did after 2018 was we reported back to all the doctors and we presented the 2018 figures to them. And each doctor was sent an individual report of their own findings. So I don't know who they were anonymized, but the statistician who did the statistics, he knew who was A, who was B, who was C, and she emailed them their own individual report. And as you can see, there was an improvement after this, showing that perhaps doctors do like to self-correct. If we split the polyp detection rate into males and females, because males are reported to have more polyps than females, you'll see again we met the benchmarks. And what we then did is we had a look to see if bowel prep made a difference. And in the 2018 figures, it didn't seem to make too much of a difference whether the prep was actually good or bad, but we did see an increased pickup rate in the 2019 figures. Next slide, please. So if we look at the age distribution of the polyps, I think what is really extremely interesting is that about 35% of the polyps were in people under the age of 50. And as you may all be aware, this is becoming quite topical, with the Americans having dropped 2 sets of their guidelines down to start polyp screening now at 45. And we do have a couple of families that come to the hospital who have FAP, which may be related to those in the younger group. And then not unexpectedly, we see a higher rate of polyp pickup as patients get older. We looked at the racial groups, and in fact, there didn't really seem to be much of a difference, although you'll see quite different figures in the Black Africans between 2018 and 2019. This wasn't statistically significant, and I just think reflects the smaller number of those patients, so that a small change in the figures gave quite a large change in the percentage, but this wasn't statistically significant. So we're seeing fairly high numbers of polyps in all race groups. Next slide, please. Okay, so in 2018, we were very lucky. We had a medical student who was attached to the research unit, and she was able to pull all the histologies that she could find and was able to calculate an adenoma detection rate. And when we pulled this out, we were a little bit disappointed because actually our pickup rate did not meet the international benchmark of more than 25%. So obviously there were some hyperplastic polyps, there was, I think, a gist. There were a couple where we couldn't find the histology, so they obviously had to be excluded because we couldn't claim adenomatous polyps if we couldn't prove them. And so our figures didn't look quite so good. But we also don't really know whether we have the same rates of polyps in Africa or South Africa as is quoted in the rest of the world. We assume we do, we compare ourselves to the rest of the world, but we don't have a lot of data from Africa, which I think Sandy may want to comment on later. We unfortunately have not been able to calculate the adenoma detection rate in 2019. The end of the data collection coincided with just before our hard lockdown. All the medical students were not allowed to come into the hospital. And so we haven't been able to calculate this. Next slide, please. Okay, I've looked at the adenomas, this time also looking at age. And again, you can see we have adenomas even in the young age group. So again, alluding to the fact that maybe we need to reconsider, do we start at 50 or do we actually bring our screening down to 45? Again, if we look at ethnicity, again, it's a similar instance across all racial groups for adenoma detection. Next slide, please. Okay, so I want to show you what we did. We compared doctor to doctor, and we sent, as I said, the individual reports to each individual doctor. Next slide, please. So what we did, first of all, we had a look at who was doing what. Obviously, we have different practices. We have physicians and we have surgeons here. And as you can see, these are the 2019 figures. So there's no Dr. B. That's a Dr. B retired. So I do actually know who that doctor is, but the rest, and I know who I am, but the rest I don't know who they are. And you can see certain people did more screening, certain people did more cancer surveillance. So at a guess, they are probably surgeons, they've probably operated on, and now they're doing the cancer surveillance. And doctors E and H were investigating anemia, so I'm assuming that they were physicians. So I see from Sandy, he's asking for if people have got data on advanced adenomas, We didn't split these into advanced adenomas. We just simply looked at the detection, Sandy, but hopefully other people may have some data to share with us. Next slide, please. Okay, so this is our cecal intubation rate. So the blue is for all colonoscopies, and the red is for the screening colonoscopies. And this is for the second year. This is the 2019 year of our data. And as you can see, across the board, all the doctors met the 90% requirement, and only one doctor, which was Dr. J, was just below the benchmark for screening colonoscopies. It is possible this is a doctor who's also working in the States, so maybe he had a smaller number where the odd one may have dramatically affected his figures, but as they are blinded, I'm not sure. But I think across the board, we can be quite happy with our cecal intubation rate. Next slide, please. Okay, so this was the median time, and it just shows you how doctors do vary. So if you have a look, the median time we should be aiming for is about 6 minutes. And as you can see, we have 4 doctors who, well, 3 over the 6 minutes, 1 who just reaches, and then 4 doctors who are underneath the line. So Edward, I see you've posted there, how is the cecal intubation rate calculated? So it's the total number of colonoscopies that a doctor did, divided by the number of times they reached the cecum. And that was in patients who we wanted to reach the cecum. So if patients had a right hemicolectomy, for example, they would have been excluded from this because you can't reach a cecum if the cecum isn't there. And we didn't insist that people document, although most of us do photo document, but it wasn't the doctors who decided that they'd reached the cecum. We have extremely well-trained nursing staff who know what the cecum looks like, they know what terminal ileum looks like, and the nurses were recording the data. And they also had a little box. So if a doctor said, well, I've reached the cecum, but the nurse didn't think the doctor had reached the cecum, they were free to write in there that they disagreed with the doctor. Interestingly, they never had to. And interestingly, the nurses just collected the data. They didn't, there was never a dispute. And a lot of the doctors would actually say, look, I'm at cecum, here's ileocecal valve, I'm now in terminal ileum. We have that conversation with our nurses because we do sometimes have medical students, we sometimes have student nurses. So we want to teach them what we are doing and what we're looking at while we're doing it. Next slide, please. Okay, so this was the withdrawal time. We're looking at the over 6 minute benchmark and then the over 8 minute benchmark. So as we alluded to earlier, different articles suggest different times. And you can see that generally the doctors who had the slower median withdrawal times also had longer withdrawal times overall. And we unfortunately had Dr. E and Dr. K who were quite quick, Dr. H a little bit too quick. But we'll show you whether that affects their polyp detection rate as we go through the next lot of slides. Next slide, please. What we thought we would do is to have a look and see, well, are those doctors who are having a long withdrawal time, are they actually taking a lot longer in the unit? So we'd also recorded the starting and the finishing time of the procedure. And in fact, it wasn't. So those doctors who were taking quite a long time to come out were actually getting to the cecum reasonably quickly. So it didn't really extend their procedure time. Next slide, please. We then wanted to look at polyp detection rates on screening. And I think this is an extremely interesting slide. So as you can see, that there were doctors who were over the 25% line, and there were a couple of doctors below the 25% line. And if you remember to the withdrawal time slide I showed you previously, Dr. E and Dr. H were quite slow, and they have a poor polyp detection rate. But Dr. K, who was also quite quick at withdrawal time, actually has an excellent polyp detection rate. And this would suggest to me that this is a very experienced endoscopist whose eyes are tuned in to looking for polyps. And I think he can argue, or she can argue, that they actually don't need to slow down because they are picking up all the polyps they need to. Whereas I think Dr. E and Dr. H maybe need to have a think about, maybe we can do better if we slow down. Next slide, please. Okay, so on this slide, what we've put the median withdrawal time next to the polyp detection rate for both years. So the gray and the blue color is your median withdrawal time, and the two different greens are the polyp detection rate. And on this slide, I want to highlight the second lot of columns from the left. So that's actually Dr. C. And what you can see in the first set of figures, the doctor had quite a rapid withdrawal time and not such a great polyp detection rate, but clearly made an effort to slow down. So achieved over the 6-minute withdrawal time with a dramatic increase, in fact, in polyp detection rate. So I think this shows that doctors really do want to do a good job. And if they've got the data that maybe they're not on a par with their colleagues, that actually they can self-correct. Even Dr. E, who still remains quite quick, did in fact slow down, and statistically so on the figures, and did have an increase in polyp detection rate, although I think could still improve a little bit more. So I see a couple of questions coming up in the chat. So Mashiko, we don't specifically use dye or NBI. We do have it. So I use dye spray in my IBD patients. I don't use it routinely in the screening scopes. And we do have NBI so that if you see something that you're not sure about, you can change over. And the odd time where you see an area that looks a bit odd, I would put some dye in just to see if it highlights anything. Someone's asking about the years of training and the type of training. I don't have that because what we did, we anonymized this. So we wanted everyone to buy in. We didn't want anyone to feel that they were going to be picked on or named or shamed. And therefore everything is anonymous. So I do not know who is who. I know who I am. There's a couple that I can probably guess, but I don't actually know who is who. And that wouldn't be fair because that wasn't the agreement that everyone agreed to have their data collected on. And the improvement in Dr. C, the intervention was that each doctor was informed themselves of their own data. And we presented this at the doctors' meeting, and we highlighted to the people who attended, that wasn't everybody, but we highlighted to the people who attended where we felt improvements could be made. And people obviously then had to decide, were they going to take that on board and were they going to change their practice? I do know that a couple of people did. When I show you the bowel prep data, I'll admit that I was one of the ones who had good bowel preps. And a number of the doctors did contact me and ask me for the information I gave to my patients and asked me how I instituted my bowel prep regime. So there were people who were wanting to improve. Next slide, please. Okay, so this is the one I was referring to about adequate bowel prep. So as you can see, there were two doctors. I've already said I'm one of them. So you now know that I'm A or C. Who got over the 85% adequate bowel prep. Dr. J was almost there. There were a couple that were around 80%, and then we had a few that were a little bit lower. And you can see that from these figures that actually our screening preps were probably better because if remember the overall figure, we only got 77% of scopes originally, whereas here a lot for the screening scopes are actually doing quite well with the bowel prep. Next slide, please. Okay, so this compares the 2018 bowel preps to 2019. And you did allude to Dr. C, and Dr. C did come to me because they admitted who they were and they asked for help with the bowel prep. And as you can see, there's been a significant improvement by just changing the bowel prep regime. So does it fall on the doctors? I think it depends on your setup. If you've got a very good nurse that can explain to the patient how to take the bowel prep, if you've got very clear instructions. Also, what kind of prep are you using? Are you using a low volume prep? Are you using a higher volume prep? Are you using an overnight split dose? So generally I use Movi prep and I use an overnight split dose. I do my scopes in the morning. So the morning dose actually starts at 4 a.m. and the patients really do not mind getting up at that time to ensure that they have a good prep. And then there is a questionnaire that all the patients are given on arrival to the unit, which asks them about what has been coming out. And if there is any doubt that it is not a fairly clear effluent, they are then given an enema. Also, if I have patients that I've scoped before who may have had a poor prep, then I tweak the prep. Or if I have someone who in their history tells me they've got extremely bad constipation, then I would tweak the prep. And that would either be giving them Movicol to see if it gets their bowels regular before we book them, or sometimes I would add in a sachet of a stimulant bowel prep earlier in the day before they start their Movi prep. So I individualize them as far as possible. Next slide, please. So if we summarize what we've seen, if we look at the cecal intubation rate, so in all the total colonoscopies, all doctors achieved the cecal intubation rate of 90%. And in screening colonoscopies, all but one doctor reached the 95%, and he was really, or she was really just below. If we look at our polyp detection rate, so we did meet the level of more than 25%, but Dr. E and Dr. H fell below that benchmark. But unfortunately, our adenoma detection rate was not achieved, and we haven't calculated it in 2019. If we look at the bowel prep, overall, there wasn't really a significant difference between the years, other than in individual doctors who'd made an attempt to improve things. And as I said, only the two doctors A and C met the benchmark of 85%. Next slide, please. Okay, so where to next? So all doctors have received their individual feedback from 2019. Our aim had been to continue with the study, but unfortunately when lockdown came, it stopped for a number of reasons. Firstly, we had to close the endoscopy unit. We weren't working with our regular nursing staff. The research department lost staff because of financial issues. So we will hopefully try and get this back on track, but at the moment we are not able to collect the data. We have seen improvement in quality parameters of some doctors, and I hope that when we've presented this to them, I hope that the others who are below the parameters will actually be encouraged to review their practice. Adenoma detection rate would be great. It is very labor intensive, but what we have done, we actually now have developed our own reporting system on a thing called Logbox, where we can upload the histology. And that'll be the next thing to see if long-term, if we can actually directly capture all this data, including the pathology, and be able to generate an annual report. Next slide, please. And I would like to thank everyone that helped, because I certainly couldn't have done this without them. So we have a research office at Bits Donald Gordon. They're extremely helpful. They helped us getting ethics for this, because obviously it is patient data. So we needed to get ethical clearance. Our patients, when they come into hospital, actually sign a thing to say that they understand it's a teaching hospital and they are happy for us to collect data. I think it's very rare that we have a patient that declines to do that. I need to thank our nursing staff, and we also had some clinical associates, because they did all the data collection. They made sure there was no missing data. And finally, all the doctors, because not a single doctor complained about taking part. They were all happy to partake. And they were all more than happy to give pointers, suggest changes. We did a little pilot before we started, and really everyone was very supportive, and they were all happy to have what they were doing looked at. Thank you.
Thanks very much, Kay. That was really quite a tour de force through many aspects, with lots of interaction during the talk. There are one or two questions that perhaps you could think about. Obviously, there's a lot of subjectivity to even using bowel preparation scales. One of the aspects that many people are moving to now is to photo document, either video document or photo document, because then you have another layer of quality control that you can assess. Are you planning to do that? Do you currently photo document your landmarks?
Yep.
Do you video selected colonoscopies, or are you routinely videoing them?
So no one's specifically instructed to do anything. So the doctors do what they want to do. But I think most of us do photo document. So certainly I will photo document appendix orifice, ileocecal valve. Or if I've got into the ileum, I just take a picture of the ileum, because we can all see it's the ileum. You can't get into the ileum if you haven't been to cecum. So There are some doctors who put it onto a memory stick, but not all our stacks allow that. So it depends which stack you happen to have on the day. I don't video. I'm not, as I said to Karen, I'm not as technically advanced as some of the younger guys. And I'm not actually sure if our older stacks can do that. The newer stacks can certainly do that. But I would photo document any pathology. So if I take a polyp, I'll photo it beforehand, and then I will photo what the base looks like after removal. And then I usually photo document inversion in the rectum, just to show that I have actually looked in the rectum.
Yes, I think it is something that we should be moving towards, because otherwise things are not reproducible. And
yes,
again, the verification of cecal intubation, again, it must actually inspect the lower pole of the cecum. I think Ed made that comment. And obviously all these individuals are individuals who have trained in gastroenterology or in colorectal surgery generally.
Yeah, so they've all had some form of training. Some were many years ago where it was more of a see one, do one, teach one. And I think over the years that has improved. Some of them have done the trainers courses. Some of them have gone on some of the training courses. So I think as a general group, they've probably had more training than many, even the older individuals that we have with us. So yeah, I think we're lucky, but I think even we can improve. Some of the things that came up in discussion is, as you will know, we have a liver unit. So a couple of the doctors are actually hepatologists largely, and there's quite a bit of data in the transplant literature actually about bowel preps in these patients. So their bowel preps are poorer, and they can be more difficult to scope at times. So they argued some of their lower pickup rates related to the patient group and type. And then they were also some of the younger patients because they were screening them pre-transplantation. So that's where some of our younger patients also come from. There's a whole load of questions here, which I'll also address while we're talking. So my screening guidelines, generally I use 50.
You're way too efficient for me. Carry on.
Oh, sorry.
Carry on. No, carry on.
I do. So I use 50-ish.
Eventually, we will have to move on to Daniel. He's waiting patiently in the wings. So
I do 50-ish. And the ish being, if someone comes to me at 47, I'm not going to say go away because the American guidelines have been brought down. Or 10 years younger than the youngest cancer was diagnosed in the family. So that's generally, occasionally you'll get someone who comes at 35, they've had 3 or 4 family members, they're incredibly anxious. And sometimes I will do that scope and then I'll say, it's all fine. You're now going to go to the normal screening guidelines. A lot of patients actually come over the age of 50, so that's not even an issue. The 50 colonoscopies was actually advised by our statistician. So we used a statistician from BITS. She did all the calculations, and she was the one who said that they needed to do 50 for the stats to work. So I'm not a statistician, and I didn't argue because she's very good at what she does, and she's very clear about what you need. So 50 was the cutoff. We've discussed so we don't have an electronic medical record as yet. We do have a system called Logbox, which now our patients all register on. And Nadine Haran, who's one of our colorectal surgeons, has put a hell of a lot of work into developing our own electronic medical record for scopes. The colonoscopy one's almost about to go live. We ran with a little bit last year and we identified some issues and they've been looked at. It's all been a bit slow again because of COVID, because they've spent a lot of time sending out COVID questionnaires and all sorts of other things which took priority over the colonoscopy reporting. Most people type their own reports and keep them in their own files at the moment.
Okay, can I ask you, can I interrupt just a little bit?
Yeah.
Can I ask you, obviously you've managed to do this and you have a dedicated pool of colorectal specialists and gastroenterologists at BITS Gordon. But what we need is national data. Don't you think it's time, or how would you go about getting SAGEs or getting I don't know whichever body you want to go through, to
So
start
if I
developing minimum data sets, however you record it.
So if
Because
our logbox data system works, it's something that is rollable out, because any practice can use logbox. So we use it in-house. It links to our hospital system. It uploads the patient's details onto it. And if we get this right, it is something that can be rolled out countrywide.
Okay.
We do not really want it to be medical aid wide. As you know, at the moment, Discovery are trying to do their own. That has, we feel, a lot of problems. It's only their patients who owns the data. And we should be collecting data on all our patients, not just on one medical aid.
Yeah. But remember, we do have a public sector where 70% of the population are sitting, and where the real question that we want to know is the adenoma detection rate in Africans, because they are the predominant population in the country.
So logbox could be accessible to the public sector. It has been discussed with them in advance. Obviously, there's going to have to be a little bit of input on their side, but it is scalable. So what we need to prove is how we get the data off afterwards. They tell me we can, and I would love, when we finally got it going, to actually see how easy that is. Because what we used for this study, we used something called REDCap, and everything had to be inputted into the REDCap in order for the stats to be done, which, as you know, that's based at the universities. So we'll need to see how easy it is to get this data off the system that's been generated. So we'll see. So watch this space.
Yes. And is it who's driving it, or who's trying to drive it? You as an individual, or?
So it's a combination.
Apologies, Sandy. Apologies, Kay. I mean, I think it's an excellent presentation, and I mean, it's really provoked. We really must move on to Daniel, and perhaps at the end pick it up again. But we really don't want Gecko to go too much over time. But Kay, fantastic presentation. Thank you, and it's led to all sorts of ideas. Thank you.
Daniel, I think over to you.
Okay, thank you so much. Thanks for the opportunity to present this afternoon. I've been asked to present on a sort of an approach to polyps. So I'm just going to give you my basic approach to how I manage polyps. And I usually base this on four things. And that's the risk the polyp poses to the patient, my skill as a clinician, which you can then individualize to yourselves, the site of the polyp as to how I can get it out, and how well the patient is to manage what I'm about to do to them. First up on this, we need to sort of have a look at the polyp risk, and I've set up a sort of a very simplistic system of what I regard as being risky polyps as pre-malignant polyps, then those are the malignant predisposition, and benign polyps being your hyperplastic or inflammatory. Benign ones I generally tend to leave alone, and then I'll remove the ones that I regard as dangerous, which are your pre-malignants then. So once you've got this list kind of sorted out in your head, you need to see what tools we've got to diagnose these polyps and make sure that we're looking at what we think we're looking at. So there's a few of those out there. The first one is white light endoscopy, which I think is what most of us are using. In our hospital, we have a little consent form for the patients where they'll write down what they understand the procedures that they're going for. And this is one of my patients who I was taking in for a gastroscopy and colonoscopy. And in his words, he said, I'm being put to sleep and then they're filming a movie in my butt and my stomach, which I think basically sums up white light endoscopy, to be honest. You're really just having a look around to see what's going on, with me in the director's chair, of course. So from white light, you really can only gain a certain amount of information. That's really about sort of the size of the polyp, the number of the polyps, the place of the polyps, and then the Paris classification. So what does the polyp look like? Its shape. As a rule of thumb, as you move along this classification from 1 to 3, you're moving more and more into the higher risk, closer to what's being an invasive cancer. So the 1s and 2s can usually not be in the once you start sitting sort of 2B, 2C, those are looking more malignant. Beyond white light, however, there are a few other techniques that we have at our disposal, and these are, a lot of them are available to everyone, a lot of them are available to no one. the bottom one we'll chat about a little bit later, is brand new. And we can see whether that's going to fit into our armamentarium. So chrome endoscopy has a look at the pit pattern as laid out by Kudo. When you do this, you spot a polyp, you have a look at it, you want to see what the pits look like, you spray some dye onto it. Now, there are some very, very expensive dyes out there. We've actually found that just buying plain old Mona's food coloring that you'd use to bake your cakes, you can actually dilute that up with some saline or water and spray that down the main channel of the polyp, and you still get an adequate assessment of what the pits look like. It's not going to be adequate for, as Kay was saying, your ulcerative colitis or your Crohn's disease, where you're trying to have a look at the whole colon, you want to spray the whole colon, but it's adequate enough for if you've got your polyp and you want to see what's going on. Once again, the further you move down the pit pattern, the more likely you are to have malignancy or an adenoma with dysplasia. And most scopes these days come equipped with narrowband imaging. All the different brands have named them different things, but they really are about the same thing. And what the narrowband imaging is you just convert from your white light to a narrower spectrum of light that shows you the blood vessels and the shape of the blood vessels much better. And this gives you an idea then of what you can do, with how pre-malignant or malignant this polyp possibly is. So, using this information, the Japanese came up with a classification system called the JNet system. And that divided polyps into 3 groups. Group 2 is divided into two separate groups. Group 1 being sort of the ones that you can leave behind, that they're fine. Group 3 being the ones that are cancer, and Group 2 being the ones you probably should remove and maybe pay a bit more attention to. The British then came along and sort of altered this into the NICE classification, and basically all that they've done is they've taken 2B and 3 and turned that into your malignant or your superficial malignant polyps, which is about what these polyps are. Moving on from that, we've got confocal laser microendoscopy. I've never seen this, I've never used it, but oh my word, the pictures you can get with this. So this basically represents live real-time histology of the polyp you're looking at. If you have a look at this diagram, you've got an objective lens and you've got a confocal imaging window. What that means is you do your colonoscopy with white light, you have a look around with your objective lens, you spot a polyp, you then switch to your confocal window and you press that up against the polyp. And these are the sorts of things you can see. It gives you an idea of whether you're looking at something that's benign, or hyperplastic polyp, whether you've got a degree of dysplasia, or whether you're looking at frank invasion. Like I said, I've not seen this. It requires specialized equipment, so it's quite pricey. And I've not seen data that it really changes what we're doing. However, where it might come into play is what's kind of being developed in Japan and in Europe at the moment, and that is artificial intelligence. So watch out, people, we're all going to be replaced by this guy. This is artificial intelligence assisted endocytoscopy. So what they're doing now is they're saying, do your colonoscopy, and the algorithm, data algorithm in your scope machine will point out the polyp to you. You then shove your scope up against the polyp. It then automatically does its own cytology, that the confocal microendoscopy, and gives you a readout. So the studies that have been done using an Olympus endocytoscope with this added software to it. They're able to get 520 times magnification. And what the system does is it beeps to show you it's seen a polyp, and you put the camera up against it, and it'll tell you what that polyp is. So I've got a couple of videos, if they'll run. This is a hyperplastic polyp. What you'll see is in the corners, this thing lights up to say, there's a polyp, I'm 95% certain it's there. Switch to narrowband imaging, push it right up against, and it takes 3 pictures. And over those 3 pictures, it tells you what's your chance of this being neoplastic or non-neoplastic. Should I remove it? Can I take it out? Next video, this is a diminutive adenoma, which I was going to look at a white light. I would have thought that this is just a hyperplastic polyp and it's small. But so it warns you, there's a polyp, go have a look, switch to narrowband imaging, stick it up against it, and all of a sudden your pit pattern and your vascular pattern is looking more neoplastic than it was for the previous polyp. So that one is in actual fact a very small adenoma. Studies that are done looking at this shows that it's very sensitive. There is a 60% false positive rate. However, you're still the one holding the camera, you're still the one deciding what to do about it. When they took it a bit broader and gave us the basic stats around it, this is looking pretty close to what humans can do. The real criticism to probably level against this is it's not better than humans. And I'm not too sure how we would ever prove that. So if we could have a system that was able to show us more than we could do, that'd be something to really invest time and money in. This one is going to have to find a different niche in our armamentarium. So now we've got a whole lot of techniques and classifications and uses to try and see what we're looking at when we're looking at it. But what are we going to do about it once we've got that information? So if you decide you have to remove the polyp, there's a number of different techniques you can use for that. If you decide you want to leave the polyp alone, you leave it alone and you bring them back whenever's next on your screening or surveillance rotation to see the polyp again. So what I'm going to give to you now is just a few techniques to remove polyps. Some of them you will have already used, some of them will be brand new, some of them you will not have skills for. And this comes back again to our discussion on your resources and your clinical skills to deal with what you're looking at, and you can tailor it to each of those. So I've grouped my polyps into diminutive, small, and large, and tried to give suggestions on the methods we can use to remove them. Once again, our polyp risk, the ones we want to remove and the ones we want to leave behind. So depending on your skill, your equipment, and your follow-up is what you're going to take out of the next few slides. So diminutive polyps defined as less than 6 millimeters. If you've got a giant biopsy forcep and you can remove that polyp entirely in 2 bites or less, you can remove it with the biopsy forcep. If you're having to take 4, 5, 6, 7 bites, you've made the wrong decision. You're using the wrong technique for that polyp. Second technique, this is a hot biopsy. What this entails is the monopolar diathermy attached to your biopsy forcep. You grab the polyp, you lift it up, and what happens then is the polyp forms sort of a circular cap at the top. You have a narrow waist underneath the polyp where the normal mucosa sort of comes together, and then you have it widens out to the mucosa that's lining the colon. You then apply a diathermy and rip the polyp off as it burns. The idea being that the diathermy will be concentrated at the narrowest point, which is the neck below the polyp. You're then able to, if you're worried you're leaving some polyp behind, don't worry anymore. You've just burnt the smithereens out of it, it's gone. Okay. However, don't do this, right? What this results in is fried specimens that you can't really assess. It also results in a few perforations to the patient if you burn them for too long. What you can also do for diminutive polyps is you can cold snare them and remove them that way. Small polyps, 6 to 9 millimeters. Once again, hot polyp biopsies, don't do this. It's not worth it for the patient. Rather move to one of the others, such as a cold biopsy if it's small enough and you're not too worried about bleeding. You can also use a hot biopsy forceps to remove it. These seal the vessels behind you. If you're very worried about a very thick neck on your polyp, you can apply sort of tourniquets and bands to it via the endoscope as well. You can do endoscopic submucosal resection, endoscopic mucosal resections, which is an EMR. This involves injecting fluid below the polyp and then using a hot biopsy forceps a hot snare to snare the polyp out, and you're left with a nice space at the bottom to show where the polyp has been removed. Large polyps, more than 9 millimeters, there's a few other techniques. So here we have a superficial spreading polyp. This one, they've used the same technique as we had in the previous slide. This is an endoscopic mucosal resection. What they've done is they've injected below the polyp, but because it's so big, they can't take it in one bite of the snare. You take it piecemeal and bite it off with bits of, in pieces with the snare. An alternative to this is doing endoscopic submucosal dissection, and I've always sort of described this as being microsurgery, really. This requires you to take a monopolar knife, needle knife, inject below the polyp, lift it up, and then cut under vision to separate the polyp off the muscularis. What's nice about endoscopic submucosal dissection is that your polyp comes out in one piece, so it's not brought out piecemeal. Therefore, you're able to assess the margins. You're able to make sure you get correct margins while you're doing it. And you're able to pin it down into a block and orientate it for the pathologist. New kid on the block, Avesco has come out with a full thickness clip. This allows you to take a polyp of up to 4 centimeters diameter. You lift it into the scope cap with a biopsy forceps, fire your clip, and then cut the polyp and the full thickness of the bowel wall off. This is a little bit tricky. If you get it wrong, you cut a hole without firing the clip and you've got a great big hole in the bowel wall. So you've got to be quite confident in how to use this equipment before you use it. It's really best to get trained on it first. Theoretically, I've also never done any of these large polyps done by hybrid techniques where you have a laparoscope inside the patient and an endoscope inside the colon. Identify your polyp, pull it up, and only sort of do a little piecemeal dissection through the side wall of the polyp, through the bowel, and not do a full-on resection. These are being practiced out there. If it doesn't work and you have to remove bits of bowel, you can do laparoscopic surgery to do colectomies and hemicolectomies. If you're not well versed in laparoscopic surgery, there's absolutely nothing wrong with doing open surgery. Results are more or less the same for the patient a year down the line. I'm a surgeon, so I tend to do things surgically. And for me, the polyp site makes quite a difference. And if the polyp is within reach of my finger or within reach of an instrument that I can stick up the bum, I'll usually go and resect it via the bum. If it's in reach of a scope, I'll apply one of the techniques we've already discussed. So techniques to get polyps out of the rectum through the anus is you can go transanally, or you can do what's called transanal minimally invasive surgery, or TAMIS. TAMIS involves inserting a 4-centimeter port through the anus and operating with laparoscopic instruments to dissect your polyp off. There is good data now to show that we should no longer be doing transanal surgery. You have worse margins left behind and worse results for the patient. TAMIS is now the way to go. New in Joburg is we finally have accreditation to start using this guy. This is called the Speedboat from Prio. It is a type of a needle knife that's used for endoscopic submucosal dissections. What's nice about it is you can inject at the same time as you can burn, and you can coagulate. When I ask for when patients are referred to me for this procedure, I usually ask that they do not have a biopsy of that polyp before they come. Use your narrowband imaging, use your chrome endoscopy, but don't take a chunk out of the polyp, because then you weld it to the mucosa. And if you have a look, when you're doing your endoscopic submucosal dissections versus your endoscopic mucosal resections, the piecemeal removal that we discussed earlier happens in the plane above the blood vessels. The submucosal dissections, the microsurgery, happens in the plane below the blood vessels of the mucosa. So when you finish up, you'll see your endoscopic mucosal resections, the blood vessels are retained. With a submucosal dissection, you have that deeper level to take more of the polyp out. And if you do a submucosal dissection, not only do you finish up with a full chunk of polyp that you can send to the lab, you also can treat a Kikuchi 1A and 1B cancer effectively just with this procedure without having to do a resection later. So it is harder to do, it is higher risk, but it does have better results if you can get it right. Thought I'd throw in something that's also still in development and not quite out there yet, and this is being developed by the guys at the clips, the Avesco clips. They're looking to make a capsule that not only takes photos, but it also swims down your bowel, and it also removes polyps, and it biopsies polyps, and it brings bits out. And so far as I'm concerned, this is pure science fiction, but hey, one day, if we can get a capsule that's going to replace the surgeon and give your patient a better outcome, I think that'll be a great idea. So just watch that space. Then, last thing that you need to be careful of when you're doing all of this is the patient. Is the patient going to manage whatever you're doing? So if you're planning on doing a big open resection in a 78-year-old with congestive cardiac failure and an ejection fraction of 10, that's not a great idea. Their heart's going to kill them before the polyp ever does. So leave that patient alone. However, if you're dealing with a young patient who's got a single polyp that's quite large that needs to be removed, go ahead and do what you need to get it out. So I've thrown a whole lot of techniques and things at you. We now need to have a look at what are we going to do about it. So I think when I went out to prepare this presentation, that one of the big things that struck me was we have a need to rationalize all of these techniques and come up with a thoughtful way of actually applying them to our patients. So I've said I want to remove those risky polyps. I've said that we need to individualize therapy based on risk, the risk versus the benefit to the patient. That also goes on my techniques, my abilities, my equipment, and the patient's ability to withstand the assault I'm going to lay on them. And I think we're getting better at it, but I think we really do need this done formally. One of the studies I came across, this is the only study I'm going to show to you, is the DISCARD-2 study, which kind of struck a chord with me. Not so much because of what it was trying to achieve, but because of what it said on its way there. The DISCARD-2 trial begins with the desire to rationalize the use of our resources. So if I'm doing a colonoscopy and there are 20 polyps, do I have to remove them all? If I do have to remove them all, do I really have to stick each one of them into a formalin and send it to the pathologist that he has to look at 20 different polyps and tell me what's going on? Do I really have to waste my time, my equipment, the histopathologist's time, his equipment, and all the money to get an answer that's actually going to make no difference to the patient and is just going to waste everyone's time and effort? And that was the question posed by this, that sort of came up in the study. So they've said resect the worrisome ones and send them for histopathology. If they're small premalignant polyps, so an adenoma that's diminutive or small, why do you want to send it for histopathology? Why don't we just remove it and throw it away instead of sending out to check what it was? We now have techniques where we can look and see, be fairly certain of what these things are. Can't we just throw them away instead of wasting everyone's time and effort? Third thing was to leave the benign ones behind. So if you're happy it's a benign polyp, don't put your patient to the risk of a polypectomy. Just leave it. Come back and look at it next time. What they did was they took narrowband imaging alone and they applied the NICE criteria to it. They found that it actually wasn't accurate enough yet. So when I say that we're close, I don't think we're there yet to be able to rationalize all of this to this degree. And hopefully in the next few years, we'll come up with a rational approach to getting these polyps out. The artificial intelligence was not used in this. It wasn't available at the time this trial was done. And I think that might start impacting the way things are done. So in conclusion, the four things that I've tried to promulgate in my practice: the risk of the polyp, the site of the polyp, my skill and my equipment, and the patient's condition to withstand what I'm going to do to them. Each of those needs to be put together to individualize the polyp and the treatment for the patient. There's definitely a need to rationalize all of this into something that we can make it better and more cost effective economically to the health of the patients and this group of patients that we're treating. Thank you very much.
Thanks very much. Ed, I don't know if you want to take over from here. Maybe I can start the ball rolling and then you take over. But I think you've really sort of said we should individualize the management based on our own skill set. But how many people have the skill sets to do big EMRs? Isn't there a case to be made for centralizing these polyps? And remember that from the little evidence we have from Cape Town and from your own, we're not seeing a huge number of large polyps in terms of volume for individuals to get very good at it in routine practice. So what do you recommend for, what's your definition of a big polyp, and do you recommend centralizing it?
Okay, so there's sort of applicability and fantasy here. Absolutely, yes. I think that it would be great if we could centralize this and have it done just by one or two centers that are high volume. That's definitely the way to go. The problem with that is in South Africa, we have massive distances to travel for these patients. If you have a look at the centralization of surgical techniques in the UK versus US, it's really taken root in the UK because it's not a hang of a distance to travel. You get on a train, you go somewhere, you're there within a day. In the US, they tried centralizing complex surgical cases, and they decentralized in the end because they ran into too many problems of patients being sent home, complicating at home, and not being able to manage or get them back in time to fix the problem. So yes, absolutely. I think these are things that we can, it's elective, it's not an emergency issue right there while you're looking at the polyp. Definitely, I'd love to see them centralized to centers that could do them. The other problem in South Africa, while I've been trying to get my submucosal dissection skills up, is that people don't want to refer their polyps on in the private sector. I found it, I want to remove it, I want to bill for the removal of it. So if I'm a surgeon looking at a polyp, I'll do the hemicolectomy, because that's going to pay for my kids to go to school. And that is a problem we've encountered. I think that you will get better results, however, if you can centralize this. The smaller, easier polyps to deal with, absolutely, it's got to be individualized to what you're capable of, what resources you have, and what the patient needs.
Yeah. My advice to the trainees, if it's more than a centimetre, then think twice about it and only consent your patient at the first sitting, and then just take a picture of it and consult your most experienced colonoscopist around you. But maybe that's just too pragmatic.
No, look, I think absolutely one of the big things is if it's a big polyp that you cannot get out, do not biopsy it. Take a photo and pass it on. When you biopsy it, you limit the things that we can do to remove.
Yes, well, thank you very much, Daniel. Yeah, I think the most important message you in your talk was the whole issue about biopsying, and if you've sort of dabbled in ESD, especially in the colon, it really is troublesome. The other group of patients where it's really a problem are patients that came that did Barrett surveillance, repeated biopsies, 10 biopsies at a go, and if there's anything to take away and you do an ESD, it looks like one of these old time couches with the buttons in it. You know, it really lifts like a couch stuck to the submucosa everywhere. So I think if that message can go home, I think it's a very important message. Also, the whole thing about centralization, I think in countries where they've perfected the technique is really places where it actually has been centralized one way or the other. And I agree with you, it's going to be a problem to centralize, sort of a national centralization is a problem in countries for many reasons, as you said, the traveling. But there are metropoles where you can actually do it on a small scale. But I think we appreciate all the obstacles to that, some of them that you've mentioned. If there are no other questions or
so excuse me interrupting. There are quite a few questions. I wonder if Akwi wouldn't unmute and maybe put on a video. It's really nice to have you, Akwi. She's really fired up and has posted a lot of questions. Perhaps you could just verbalize a few of the important ones.
Sure.
So Akwi, introduce yourself from Brown University. You're at Brown at the moment, huh?
I am.
Yeah. Introduce yourself. It's very nice to see you.
Menendo. Nice to see everyone too. These have been fantastic. I did have just sort of, I guess, I'm an interventional gastroenterologist.
Where are you from? Just tell us where you're from.
Yes, so I am actually a Zambian Cameroonian, but I'm based at Brown. COVID kind of messed up everything, but I do a lot of work across our continent. In terms of traveling back and forth. And the most recent work was setting up ERCP in Nigeria. And I'm hoping once this COVID situation is done, I'll be able to travel again and meet everyone in person. I try to attend these meetings. I think it's been fantastic and I really enjoyed them. I think some of my questions, I guess, that I had on here, I just needed clarification about the polyp resection component. So when you mentioned, is it that when you see a polyp and from your endoscopic view, it appears non-adenomatous, you would leave it as is, or do you go ahead and resect it?
So if I'm fairly happy I'm looking at a hypoplastic polyp, I actually do leave them alone. Okay. What I have done is if I have a whole bunch of them, I'll probably biopsy one to be sure. But if there's a small polyp that I'm fairly happy is hypoplastic, I'll leave it behind and go back later on to have a look at it. I see you also asked a question about the fluid for EMR.
Yes, yeah. What do you use to lift?
So I'm using Voluven, to which we add a bit of patent blue or methylene blue, whichever we've got.
Okay.
And for my ESDs, I'll use the Voluven with a little bit of patent blue, and to that I add hyaluronic acid, hyaluronate. I actually just go out and buy, there's boxes of eye drops that often have it in. And I just put a ml of eye drops into about a half liter of Voluven. And I find that it does seem to keep the polyp lifted for much longer. In terms of the ESDs as well, you don't want it too dark blue, so you still want to be able to see the tissues as you're cutting. So sort of as a rule of thumb, I flip the bag over, and if I can still just make out the writing, then I know I've put enough in.
There's a question from Kay. How good do you think we are at differentiating the pit patterns? I'm not comfortable, especially considering the possibility of sessile serrated lesions.
So the sessile serrated are the ones that tend to be more sneaky, that you struggle to identify. I must confess, I usually will have a look at the pit pattern before. I'll actually narrowband image it first, then flick back, spray the dye and have a look. And if they correlate with what I'm thinking, I'll be happy with my decision. The pit pattern is not going to be the be all and end all of what I'm using though. I definitely correlated with other things to try and fit it into one of those criteria.
Good.
Polyps involving the dentate line of the rectum. What injection do I use? I actually, for them, to be honest, I actually just use saline because they're so low down and quick and easy to get out.
All right. If there are no more comments, Chris, I think we're well over.
Yeah.
Shall we conclude? So it just remains for me to thank the speakers for really nice and actual and thought-provoking presentations. Also to the audience, people that attended, thank you very much. Also ECHO UNM and ECHO India and the ECHO India team that are really sort of supporting us in this. And then just some housekeeping. The feedback, there is a feedback form available in the chat. And then also recordings will be available of the sessions on the Gastro Foundation website. Then just next week's gecko is IBD gecko, and it's going to address the issue of fibrostenotic Crohn's. And then lastly, just thanks to the Gastro Foundation and also Cheryl and Karen that every week puts this meeting together. Thanks a lot.
Bye-bye.
Bye, everyone.